Hopefully everybody can see my screen now. Thank you so much for joining us. Today we're going to be talking about the healthy aging brain. So here you can see each of us who's going to be talking today. I'm Dr. Jodie Gawryluk. I'm Associate Professor in the Department of Psychology at University of Victoria, and I'm also a clinical neuropsychologist. Lisa and Ashley, would you like to introduce yourselves?
Sure. Hi, everyone. I'm Lisa Ohlhauser, and I'm a graduate student at the University of Victoria. So I'm completing my PhD in clinical neuropsychology under the supervision of Dr. Gawryluk.
Everyone, my name is Ashleigh Parker, and very similar to Lisa, I am also a student studying under Dr. Gawryluk, and I'm focusing on neuropsychology as well. And yeah, really happy to be here today.
Thank you. So before we get started today, I wanted to acknowledge with respect the Lekwungen peoples on whose traditional territory the University of Victoria stands, and the Songhees, the Esquimalt, and Wasanich peoples, whose historical relationships with the land continue to this day. Here's an overview of what we'll be talking about today. We're hoping to answer a series of questions. So you can see those questions here. We'll talk about what is neuropsychology. We mentioned that we are neuropsychologists. They're training to become clinical neuropsychologists. So we'll talk about that. Why is it important to understand aging? How do thinking skills change in older adulthood? What is subjective cognitive decline? And what are some tips for healthy aging? So hopefully you'll have answers to all these questions by the end of the session today. And to get us started, I'm going to turn our first question over to Lisa.
Thanks, Jodie. Yeah, so often there's a lot of medical terms and different specialists in the medical field. So I thought it would be really helpful for us to discuss, like, what is neuropsychology? So a clinical neuropsychologist is a professional psychologist who has specialized training. And really, the specialized training is in brain behavioral relationships. So often they're involved in the assessment and treatment of people with any sort of condition that might affect the brain or the central nervous system. And the central nervous system actually comprises the brain and the spinal cord. And so we treat people across the lifespan. So there are specialists who are very focused on pediatrics, who might be focused on the assessment and treatment in young children. And then there's other people that might be more focused towards adults and older adults. If you can switch on to the next slide there. Thank you. Yeah, so there are so many confusing terms. There's psychology, clinical neuropsychology, there's psychiatrists, so many different types of doctors. So I thought we'd start with a little bit of a game. And if you go to the next slide there, we are going to play a little game of true or false. So I'm going to put a statement on the screen and ask you whether this is true or false. And you can answer this to yourself, or you can feel free to enter your response into the chat, whether this is true or false, and maybe some reasons why you might think it might be true or false. All right, we'll go to our first question here. So the first one is, all clinical neuropsychologists are clinical psychologists. Is that true or is that false? So I'll give you a few moments to think about that and to put your answer in the chat or to answer to yourself. All clinical neuropsychologists are clinical psychologists. I'm seeing thumbs up. I'm seeing some people say true, some people say false. I'm guessing false. It's okay to guess too. Oh, we've got some thumbs down emojis too. Oh, so it's really mixed, it sounds like. Okay, let's switch to the next slide and we'll debunk some myths here. So all clinical neuropsychologists are clinical psychologists. Yeah, this is actually true. So a neuropsychologist is basically a psychologist who has specialized training in brain behavioral relationships. So we train as psychologists first. So the training program that myself and Ashley are going through, We're trained to be professional psychologists, but we have specialized training on top of that to help to assess and treat people with conditions that affect the brain. So we also do everything else that a general psychologist would do in terms of therapy and assessment for sort of general mental health concerns as well. Yeah, so we did have really comprehensive training. All right, let's try another one here. Oh, and here I was just going to go a little bit further into the different subfields of psychology. So I just wanted to share that there's lots and lots of specialized areas within psychology. And often this is divided into something we call sort of pure psychology and applied psychology. So pure psychologists are really those kind of like classic academically focused people who may be doing lots of research at universities, and maybe all their interactions are typically with like research participants and dealing with sort of theoretical psychology. Whereas applied psychology is really focused on the actual application of psychology in specific populations. So this might be in schools, this might be in hospitals, this might be in the workplace, or can be even in like, there could be forensic psychologists who practice primarily in like the legal field. But so really, clinical neuropsychology falls under this umbrella of clinical psychology. And so it's that specialization of that. So it's kind of this really rare specialized training. All right, and if Jodie, you want to slide on to the next slide, I'll just show you about our training as well. So Ashleigh and I are both going through this process right now, and we've both completed a 4-year bachelor's degree, and then we've also done a master's degree where we do lots of coursework. We do research as well. So we had our own research projects that we defended for our theses, and then now we're entering into our doctorate program. So again, it's more coursework, more practicum work, and we also complete a more extensive dissertation. And then on top of that, in that 5-year doctorate, the last year is what we call a predoctoral residency, where basically we go and we work as a psychologist or a neuropsychologist under supervision for a full year before we actually complete all of our training. And then after that, we go and get registered. And there's a whole process that goes with that as well. So it is quite a long process where we do lots of education and training. So we're really well equipped to assist people with conditions that affect the brain. All right, we got another question for you. So we'll switch to the next slide here. Here's another one. A psychologist is just another name for a psychiatrist. What do you think? Is this true or is this false? Psychologist is just another name for a psychiatrist. I see false, 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 false. Lots of thumbs down. Yeah, absolutely. So we go on to the next slide here. Yes, so psychologists and psychiatrists are different. We have different training experiences, but we often end up kind of working in similar places. So that's why I think these can kind of get confused, and often we're working with similar populations too. So this is why they can get confused. But yeah, a psychologist is different from a psychiatrist. And just on the next slide, I'll show you a few reasons why this is. So I talked a little bit about how a psychologist trains and has a PhD and completes basically a training module that we call a scientist practitioner model. So we train and do a lot of research, but we're also practicing and doing clinical work with clients and patients. And a psychiatrist goes to medical school for 4 years after that undergraduate degree, and then they complete, I think it's about 5 years of a residency training in that specific specialization of psychiatry. So different training experiences. And the big difference is really about the prescription of medication. So psychiatrists, since they are medical doctors, they are equipped to prescribe medications, whereas psychologists typically, I mean, we do not have the requirements to prescribe medication. So that's really where the big difference lies. But again, they're often very similar in that we can both diagnose and treat psychological disorders, and they can both be called doctors in the medical field. All right. I think we can go on to the next slide here. And yeah, so where do these neuropsychologists work? Well, you can find them in hospitals, you can find them in universities like Dr. Gawryluk. They can work in private practice. Sometimes you'll see them working in affiliation with different community organizations or non-for-profit groups. Sometimes they can work in government organizations in more of like a management role. You can also see them working in the military or legal fields or in sort of forensic settings as well. And sometimes neuropsychologists will work in a mix of these things where they might work publicly in a hospital, but they might also have a part-time private practice as well. So that might be where you would run into some of these folks. All right, and I have one last question for you guys for the true-false. So here's this one. Medical doctors can refer patients to clinical neuropsychologists for specialized assessments. Is that true or is that false? Oh, I'm seeing a thumbs up from Jenna. Lots of people are saying true, and Susanna as well. Thumbs up. Yeah, absolutely. So this is certainly true. So we can go on to the next slide here. Absolutely true that medical doctors can refer patients to clinical neuropsychologists for specialized treatments. So something we do would be a neuropsychological assessment. And I see a little question in the chat that what would be their role in the military? So sometimes you basically do the same work as a neuropsychologist within the military, within a military population. So for example, if someone had a brain injury in the military, let's say, and they wanted to know, how is this person still functioning? We could do a comprehensive neuropsychological assessment to figure that out, where that person's strengths and weaknesses lie and where they might need additional support. So again, a neuropsychological assessment is really helpful for diagnosis. So sometimes if someone's running into cognitive problems, it's kind of a slower process. Maybe it's happening in older age and they're kind of wondering what's going on for this person. It might be helpful to clarify based on their cognitive profile. We can kind of tell whether this is going to be something that's progressive or something that might maybe stay more stable. We can also help to monitor progress over time. So if we are concerned about someone having a progressive decline, we could assess them and then assess them again a couple years down the line to see if there is any significant change. We can also provide treatment recommendations and also determine access to specific services that might be beneficial to that person. So this is really just a broad overview of this. And it really depends on the specific circumstances of why that person was referred for assessment, about how we would tailor it to that person. And just on the next slide here, I just talk a little bit about who might see a neuropsychologist or why might you be referred. So again, in older age, sometimes we have changes in our cognitive functioning or our ability to function and in the workplace or in the home. And people might be wondering what's going on and you know, is there a neurodegenerative disorder at play? And if so, maybe what type of neurodegenerative disorder? A neuropsychological assessment could really help us to capture what's going on for that person. Sometimes people suffer from a brain injury. So that could be a stroke. It could be like a traumatic brain injury. So that might be something where someone hits their head and that affects their brain. Or sometimes there can be certain infections that can affect the brain as well. So we can also determine a little bit what's going on for that person if that might be the case. You can also have neuropsychological assessments for certain psychiatric conditions or psychological conditions like depression, anxiety, or schizophrenia or bipolar disorder. And then also, sometimes it can be really helpful for surgeries as well to determine whether someone's a good candidate to have brain surgery, for example, in the context of epilepsy or even for Parkinson's disease. There's certain types of treatments that can stimulate the brain. So deep brain stimulation for Parkinson's disease. So you might have a neuropsychological assessment to determine whether you're a good candidate for that type of surgery. And then after you have that surgery to determine how that went. All right, and then so what is the process of this assessment? Well, typically we'll have an interview, and during the interview, the neuropsychologist is going to ask you all about your background, what you're concerned about. So if you ever go for one of these assessments, it could be helpful to write down a list of what your concerns are, just so that you have it all in mind when you come to that interview. They may ask you about your educational background and your medical history, and just your social history and circumstances and what kind of supports you have in your life currently. Sometimes we'll also interview someone who is close to a person who's referred with their permission, of course. And that can also help us to better understand what's going on for that person, and get a better sense of how that person might be functioning in the real world. And so the testing portion, which Jodie will talk a little bit about in a little bit, is really a paper and pencil test and sometimes computerized test to really capture specific cognitive abilities. So we really want to understand how your brain is functioning. And this assessment really helps us to capture that. And you don't have to study for this. It's really just to capture how you're doing in the current circumstances. After that, the neuropsychologist takes all that information, all the background information from the interview and all the results from the testing, and we'll basically interpret that in the context of that person's situation. And we'll write a report, and then provide some feedback for you for what the results of the assessment were and any sort of recommendations that would be helpful in that specific circumstance. So yeah, this can be a really helpful assessment to be completed for people. And so next, I'm going to turn it back over to Dr. Gawryluk, and she's going to talk a little bit more about aging.
Thank you so much, Lisa. That was a great summary of clinical neuropsychology. So it's also a good base for what we're going to talk about next and understanding how we would want to know about why it's important to study aging and how thinking skills can change in older adulthood. So here you can see a figure from Statistics Canada, and this is showing that Canada now has more seniors than kids under age 15, and this is happening for the first time in history, and it's a trend that's expected to continue. So our population demographics are really changing, and we have more older adults than ever. And one of the reasons for this is that people are living longer. So it's really exciting to see. On this figure, you can see the number of people that are living to be age 100 years and older. And you can see here that that's also projected to increase over time. So people are living longer and longer. And that's part of why it's really important to study aging. We want to know not only how can we live long lives, but we want to know how can we live long and healthy lives. So what do we know about how thinking skills can change as we get older? As Lisa was talking about, as clinical neuropsychologists, we want to think about all the different types of thinking abilities that people have, and we really divide this into unique aspects. So thinking about intelligence, language, memory, processing speed, attention, visual spatial skills, and executive functioning. So I'm going to talk a little bit about each of these next. I'll tell you what these terms mean, how they might change over time, and I'm also going to give you some examples of tasks that we might use in an assessment, but I wanted to emphasize first that these aren't the exact tests that we would use in an assessment. They're just examples that we've made up for today, so don't worry too much about how you're doing. It's just for fun. So one of the first thinking abilities that we can consider is intelligence. And when we think about intelligence and aging, it's really helpful to split this idea up into two different concepts. So one is crystallized intelligence, and this is really our knowledge of facts that are rooted in our experiences. And this type of intelligence actually increases with age. So we know that as we get older, we have more life experience, we have more knowledge and wisdom, and older adults tend to perform better than younger adults on tests that involve crystallized intelligence. The part that gets trickier is something called fluid intelligence. And this is our ability to think and reason abstractly. So when we're doing kind of tasks that are new for us or flexible or more complicated, some studies suggest that this type of ability begins to decrease in mid to older adulthood. So you might expect to see some changes there. Another really important thinking skill that underlies a lot of different thinking abilities is processing speed. And this is exactly as it sounds like. It's how fast we can process information. And this is one ability that we know slows down as we get older. So processing speed becomes slower in terms of both cognition, and our motor skills can become slower as we age. In an assessment context, we want to look at processing speed so we can understand how quickly people can perform tasks. And to do this, we usually give timed or speeded measures. So I'm going to give you an example next. If you can participate along with me in the chat, I'd like you to tell me as fast as you can all of the words that you can think of that start with the letter N. Go ahead. Newt. It's a good one. Night, never, not, no. Great. Nice, neat. Now, next, near, note, 9, noon. Excellent. So you can see this is hard to do when you're put on the spot. Great, Maureen's coming up with some more ideas. Wonderful. It's hard to do when you're put on the spot, but doing these activities as fast as we can and measuring that ability in an assessment lets the neuropsychologists know how quickly you're able to perform these activities. And that can influence a lot of different other thinking skills. Neuropsychologist, great one. Can influence a lot of different thinking skills and how quickly we're able to make decisions and things like that as well. So another thinking ability that we measure is attention, and it's also helpful for us to divide this up into different concepts. So for attention, we can think of this as either simple attention or complex attention. And simple attention really refers to our ability to focus and concentrate on something. So I'm going to give you another example. I want you to listen carefully to the letters that I say, and when I'm through, I want you to type the letters in the chat in the same order that you heard them. Okay? Are you ready? E-T-L. Go ahead. Great. Okay, here's the next one. S-P-G-R-T. Go ahead. Well done. Okay, here's one more. B-K-N-G-F-D. Go ahead. Great. So for the most part, everybody's doing really well with that. And simple attention does tend to be preserved into older adulthood. So we don't tend to have problems with that as we get older. What becomes more difficult is what I called earlier complex attention. And so this is more complicated skills like switching back and forth between different tasks or doing more than one thing at a time. And so I'm going to get you to do something a little bit different next. I want you to look at the shapes that I have on the slide here. And I want you to tell me the color of the first shape, the name of the shape for the second one, the color of the third one, the name of the shape for the fourth one, and the color of the fifth one. And you can type that into the chat as quickly as you can. You're all doing great. Wonderful. So that kind of switching back and forth with your attention is something that can become trickier as we get older. And that's just an example of this complex type of attention. There's other types of attention that we consider complex as well. So this was like an alternating attention task where we're going back and forth. Another type is called selective attention. And this is when we want to pay attention to one aspect of what's in our environment while we're ignoring other aspects. So an example might be when you're trying to listen to one person talking to you in a really noisy room and you're trying to tune out the rest. And that can become more difficult. Another example is what we call divided attention or multitasking, when we're really trying to do more than one thing at a time. So if you're trying to cook a new recipe and talk to somebody on the phone at the same time, that can become really tricky as we get older. And it's really helpful for us to understand attention because it can underlie other types of difficulties like memory. So if we're not paying attention to things, we're not going to be able to remember those things later. And it also overlaps with some other types of thinking abilities. So that complicated type of attention or complex attention also can overlap with what we call executive functioning. And so executive functioning sounds like a big term, but it's really kind of an umbrella term that means a lot of different higher level thinking skills that are controlled by the front of our brain. So things like decision making, problem solving, planning, or multitasking are all different types of executive functioning. And these are skills that can become more difficult as we age. So especially when we're performing new tasks that are complicated or abstract, that ability can get more difficult as we get older. Now I'll talk a little bit about memory. And this is the most common complaint that older adults have in terms of changes in their thinking skills or worries about memory. And there's a lot of different ways that we can think about memory. One way is to think about it in terms of recent memories and more remote memories. And so when we talk about recent memories, it's things like remembering what did you have for breakfast this morning? What did you do yesterday afternoon? Those types of questions. And that type of memory can decline as we get older. But what tends to be more preserved or we don't see changes in is remote memory. So that could be questions like, what are the names of your kids? What was your favorite hobby growing up? And those kind of older memories tend to be more preserved over time. In an assessment, we might ask you to remember things like lists of words. So I'm going to give you a task now. I'm going to read a list of words to you, and I want you to try and remember the words that you hear. Okay? Here we go. Shirt, chips, corn, pants, hammer, hat, screwdriver, cheese. Okay, now I'd like you to type into the chat and tell me which of these words I said. Did I say shirt or socks? I'm seeing a lot of shirts. That's right. Great. Did I say chips or candy? That's right, I said chips. Great work. Did I say corn or carrots? Corn, you got it. Shorts or pants? I see a lot of people saying pants, and that's right. Wrench or hammer? Hammer, that's right. Glove or hat? That's right, I said hat. And the last one, meat or cheese? See a majority voting for cheese. That's right. So as we get older, beginning to kind of freely recall lists like that can become more difficult. But if you're given choices like I gave you, that's not as challenging. Um, and people can also have more difficulty with what we call prospective memory. So remembering to do things in the future, like remembering to take your medication with breakfast tomorrow. And so we can use different strategies to try and help with those things, like setting an alarm or a note in your calendar to remember to do those types of things. And then on the other hand, types of memories like what we call procedural memories are more preserved, and that represents our different skills. So the ability to play the piano or ride the bike, if you learn how to do those things, those types of memories tend to last. Another area that we look at is visual spatial skills. And part of this can be visual construction. And this is the ability to take things that are in multiple parts and put them together into a whole. So something like building a piece of IKEA furniture. And this can become more difficult as we get older. You can see an example here of a task where you could see an object that's broken down into different parts. And I'm going to ask you to see if you can put those different parts together and let me know what you see here. Kind of like doing a puzzle. What are you looking at? A bucket or a pail, exactly. So you can see if you can put those different parts together. You're looking at a picture of a bucket or a pail. It can also become a bit more difficult to navigate ourselves around in new environments, but the ability to navigate in our own familiar spaces are maintained as we get older. And then thinking about language, our vocabulary and our ability to comprehend speech, and our ability to name objects, this is all stable as we get older. So I'm sure most of you can tell me what the picture is that we're looking at here. Can you type it into the chat? Right, so we're looking at a duck or some kind of bird. Exactly. Great job. So you can see looking here, it is normal to experience some changes in our thinking abilities over time as we get older. And you could also see that there's kind of variability across the different cognitive tasks that we looked at. So some things are stable, some things people get better at, and some things become more challenging. And it's like that between individuals as well. So different people can experience different trajectories of aging, where some people remain really stable over time. Some people tend to improve over time at these different thinking abilities. And then some other people see declines over time that are more than we would expect with normal aging. So I'm going to turn it over to Ashleigh next to tell us what is subjective cognitive decline.
Yes, thank you. I'll go into that now. Do you want to show the next slide? Yes, so here in this figure, it's showing us the trajectory of cognitive decline in normal aging, as well as the trajectory of cognitive decline in non-normal aging, or something we would expect in dementia. Cognitive decline is shown on the vertical axis, where the lower points on the graph represent a more significant level of cognitive decline, while the horizontal line shows time over years. So first, I want us to pay attention to the top purple line for just a moment. Here, this line shows a modest decline in cognitive abilities over time. Some of these declines represented here map on to what Dr. Gawryluk was just discussing with us. It's completely normal for there to be some modest declines in some areas of our cognition as we age. Now I'll talk about that other line below the purple line of normal aging, and this trajectory is very different over time. And this trajectory would represent what we may see in someone who is living with dementia. You can go on to the next slide. So I'm going to start on the bottom right here, and this box is considered the most severe of cognitive decline because someone here in these phases of dementia would show levels of cognitive impairment that would interfere with their ability to carry out their everyday abilities. You can go to the next one. And then if we move just a little bit to the left, you may have heard of this term called mild cognitive impairment, or also known as MCI. So here in this phase, an individual may be experiencing some cognitive changes that are concerned to themselves and or to their loved ones. And in MCI, one or more cognitive domains are significantly impaired, but their abilities to carry out their normal daily activities is relatively preserved. So although MCI is the first stage where detectable differences in cognition can be found, as on neuropsychological assessments or using similar tasks to those that we just did together, here with people with MCI, there's already irreversible damage to the brain. So in my research, and as well with Dr. Gawryluk, we think it makes a little bit more sense to start looking a little bit earlier at a preclinical stage known as subjective cognitive decline. And that's the research that I focus on. So in SCD, or subjective cognitive decline, here in this phase, an individual experiencing the decline may notice some differences in their cognition, but this decline would not be detectable on neuropsychological tests, meaning that someone in this phase could still perform within the normal range on these pencil and paper assessments, even though they're noticing a problem in their own cognition. Now, I don't want to set off any alarm bells here with what we might be expecting, because we do expect to see some of these declines in cognition over time in normal aging. So I'm going to talk a little bit about some symptoms we might see in normal aging on the next slide. So how do we distinguish between symptoms of cognitive decline from normal aging or from something bigger like dementia? So some of the symptoms could be not being able to remember details of a conversation or an event that took place a year ago, or not being able to remember the name of an acquaintance. You might forget things and events occasionally have difficulty finding words, and you're worried about your memory, but your relatives and those close to you aren't. So when we're thinking of more serious complaints, that could include some things on the next slide. And that could be not being able to recall details of recent events or conversations that you've just had, not recognizing or knowing the names of your own family members, forgetting things or events frequently, having frequent pauses or substitutions when finding words or trying to think of a word, and your relatives are worried about your memory, but you yourself are not aware of having any problems. So all of these examples here could lead someone to feel some differences in their cognitive functioning. And people with subjective cognitive decline don't necessarily refer to someone who occasionally misplaces their keys or their cell phone or forgets the name of someone they just met. People who experience subjective cognitive decline would maybe refer to someone with more serious issues or symptoms, or maybe would fall between these two categories we just mentioned here. And what a lot of people want to know is, how do I protect myself from developing these more serious concerns? And how can I live and age more successfully? So I'm going to hand that back over to Dr. Gawryluk to talk a bit more about this.
Thanks so much, Ashley. So I'll tell you about some tips for healthy aging next. And like Ashley was just saying, what we really want to know is how can we age successfully? And when we think about successful aging, we really can think about it as being these three different things working together. So we want to avoid disease and disability. We want to maintain high cognitive function or maintaining those thinking skills and physical function. And we want to be able to engage with life. And those three things together really represent successful aging. And I have a picture here of Harriet Thompson, who is a marathon runner that started running marathons when she was 76 years old, and she's still running them at 91. And I think it's just so inspirational to think that it's never too late to start taking up these new hobbies and engaging with life and maintaining your kind of physical activity level, which can be really helpful as we get older. So when we think about healthy aging, there are some protective factors as well as some risk factors. And when we look at the protective factors, what we know is that it is helpful to have a higher education level that can be protective for our brains and for our thinking skills. It is helpful to be physically active. And it's really helpful to maintain social contacts. So, getting together with friends and family and being able to have conversations and things like that, it uses a lot of thinking skills. So, keeping up with those activities is really helpful. And then on the other hand, there are risk factors such as hearing loss, hypertension, which is high blood pressure, smoking, depression, and diabetes can all be risk factors for cognitive decline. And so, one of the really important takeaways that I wanted to give to you is that these are all modifiable. So, if you're having trouble with hearing or your blood pressure and things like that, talk to your doctor because these things are treatable. And working on managing symptoms like depression or diabetes, that's really manageable as well. So it's just starting those conversations and talking to your family and your doctor to change those risk factors and maintain your high thinking skills. That really brings us to these tips for healthy aging that I have here. So you can see, stay active with your hobbies. If there's things that you like to do, keep doing those things. If you like to play cards with your friends, if you like to go bike riding, all of those things are really helpful for your thinking skills. Like I mentioned, it's important to stay social. So that's actually a protective factor and helps us maintain healthy aging is maintaining those social connections. Keep moving. So keeping up your physical activity level, doing things that you like to do, and it's never too late to get started with new hobbies. You want to keep eating well, so just maintaining a balanced diet can be really helpful for maintaining our brain health as well. And start the conversation. If there's things that you are concerned about, if you do have subjective cognitive decline, or if you're worried about some of those risk factors that might apply to you, then talk to your family and talk to your doctor, reach out and start the conversation because a lot of these things can be helped and can change those trajectories to help you have healthy aging. Now, I'll just briefly talk a little bit about the research that we're doing in our lab. And what we do is we use MRI or magnetic resonance imaging to take pictures of the brain that help us look at how the brain looks in terms of its structure, all the different connections in the brain, and how it's functioning. And what we're interested is in looking at these different things and how they relate to some of these risk and protective factors. So how do they relate to cognition, those different thinking skills that we talked about? How does it relate to mood, lifestyle factors like physical activity level, and genetics? Are there differences between people based on these different behaviors or risk profiles? And we want to use these types of techniques to understand both healthy aging and trajectories of cognitive decline, like Ashley was talking about with subjective cognitive decline and Alzheimer's disease, as well as other neurological conditions like multiple sclerosis and Parkinson's disease. So I just wanted to highlight some of the research that Ashley and Lisa are doing. Maybe each of you could just tell us a little bit about what you're up to. Ashley, did you want to go first?
Yeah, I can go first. So yeah, I'm looking at differences in brain structure and function between individuals who report subjective cognitive decline. And for my PhD, I'm working specifically with a cohort of all women, which is going to be really interesting. So that's with the Women's Healthy Aging Project that is based out of Australia. So that will be some really interesting stuff to look at with the MRI, as well as all those different factors like mood, lifestyle, physical activity, education level. So we really want to get a good idea of who are these individuals with these complaints, and is that actually going to tell us who could maybe progress on to something like dementia and maybe not. So it's going to be really important for us to see if this complaint that people have is indicative of something, or maybe it's okay if you have these, if you experience these complaints that, yeah, you can still age successfully and live a very healthy life.
Thanks. Lisa?
Yeah, thanks. Yeah, for my dissertation, I'm looking at differences between males and females in terms of their actual brain structure within healthy aging. And then also if there's differences in their aging trajectories between males and females. Since we know that a lot of neurodegenerative conditions can actually differ in prevalence and course between males and females. So without those diseases and just the normal aging trajectory, do we actually see some differences there? So that's something that I'll be investigating in a few different studies. Mm-hmm.
Thanks. Yeah, and I also wanted to mention that one thing that's really important to us is that we're doing dementia-friendly research, and we're really interested in incorporating people who have lived experience into our projects. We really value your opinions and would love to hear from you if you're interested in participating in research or giving us advice on our studies. If there are certain questions that you really want answered in this type of research, then we would be happy to talk with you about that as well. I'll turn it back over to Avery.
Wonderful. Thank you so much, you three, for that wonderful overview of healthy aging and the work that you do and subjective cognitive decline. I learned so much. I loved the interaction in the chat box. I think that we had a lot of fun there. So now it's time for the Q&A session. So I'd encourage you to type any questions that you have in the chat box, and then I can pose it to our three researchers here. If any questions come up for you afterwards, you can also call our First Link Dementia helpline, and they can connect you with my colleagues who are on our research side of the society, and we can also help answer your questions. But if any questions have come up for you today, please type them into the chat box. Okay, so I see a first question here, wondering how they can participate in research. So as well as the research that you're doing, and then research more broadly speaking.
Thank you for this question. Absolutely. If you're interested in participating in research with us, I would encourage you to send us an email. Maybe Avery can put my email into the chat for everybody. And I would be happy to talk with you about that. If you're interested in research more generally, or interested in becoming involved as somebody who is able to advise on research projects as a partner, then I would encourage you to look at the Reach BC website, where you can sign up to receive information about different studies that are going on in your area, or opportunities to become involved as a person who has lived experience and offering your expertise that way.
Perfect. So I'm putting the link to Reach BC in the chat box, and then I'll put Jodie's email in just a moment. Okay. At what point should we talk to our doctor about subjective memory decline? And what should we expect our doctor to do?
You want to take this one, Ashley?
Yes. Can you read it one more time, Avery? I didn't see it in the chat.
Yeah, no worries. It was sent privately to me. At what point should we talk to our doctor about subjective memory decline? And what should we expect our doctor to do?
Yeah, well, I don't think that there's anything you necessarily need to wait for to start this conversation. If you do have any concerns, that's what your healthcare provider is there to do, is to support you in your concerns. And maybe something that would get done is a referral to a neuropsychologist, and maybe you would undergo like a neuropsychological assessment to see if there is any objective changes, or maybe there's some shorter sorts of assessments that could be done in-house or maybe just at your local hospital. I think there are some different seniors outpatient clinics that could help with this as well. But yeah, I would expect your doctor to, if they didn't have a great handle on what to do, they would refer out for that and get you to the place that you need to go. But the first step is really having that conversation with your doctor.
Thank you so much. Okay. Another question here is wondering about the relationship between alcohol consumption and dementia.
Did you want to take this one, Lisa?
Sure, yeah. Yeah, so we know that really extensive alcohol consumption can be really harmful for your cognitive health and overall health, especially in terms of affecting your memory. There's a certain type of condition called Wernicke-Korsakoff's that can cause a really severe memory impairment, and it's quite selective to memory. So if alcohol is something that is a problem for you and something that you have difficulties with, then I certainly encourage you to approach your doctor and to look into other ways that you could cut down on your use. Of course, always using alcohol and other substances in moderation is certainly recommended. But yeah, we do know that alcohol is really harmful for your brain health. So reducing your use as much as possible is really recommended. Is there anything you'd like to add there, Dr. Gawryluk or Ashleigh?
Yeah, I echo your comments, Lisa. I think especially in excess, it can lead to those conditions. If you're finding yourself kind of drinking most of the day, every day, it can cause some real deficiencies. But those things can be helped as well. So seeking help for that is really important because sometimes that cognitive decline can be reversible if it's caught early on, which is different than kind of a typical Alzheimer's disease profile. So it's really important to get help and to be as honest as you can be with your care provider about how much alcohol you're having, because a drink every now and then isn't going to hurt your brain. But when it's becoming a problem, an everyday kind of problem, then we start to worry about those types of conditions.
Thank you so much. So I'm seeing another theme, a few questions here relating to kind of what the next steps are after you've talked to your family doctor about subjective cognitive decline. So a few questions here. Can you request to be referred to a neuropsychologist? Is that always the next step? When does that usually happen?
Yeah, I think if you are really concerned about how you're doing in terms of your thinking skills, then it's definitely worth having a conversation with your doctor about that. They might be able to give you some quick tests while you're with them to see how things are going and if there's anything that they're really concerned about. And you can ask for a referral if that's something that you're interested in as well. You can be seen by a neuropsychologist through the hospital system. And so those referrals can take a little bit of time. And there's also private neuropsychologists that can do these assessments in the community, and that tends to happen just a little bit faster. But those are a couple of different ways that you can get to see a neuropsychologist, and they would be able to look at, exactly like Ashleigh was saying, if your cognitive profile looks like normal, healthy aging, and your worries are truly subjective, or if there are changes that are more significant than we would expect with normal aging, they would be able to pick up on that. And it is always helpful to identify these things earlier on, because there are more things that we can suggest to help change those trajectories and give you a more positive outcome.
Thank you so much.
I just
Yeah,
wanted to add one thing. I saw another question about, can we truly tell the difference between normal aging and subjective cognitive decline. So where my research really comes into play is I'm looking at brain-based biomarkers between individuals with subjective cognitive decline versus those healthy controls who do not have those complaints. So at the moment, yes, the real part where subjective cognitive decline comes in is that there isn't that objective cognitive decline as we see on the neuropsych tests. So the way that hopefully we can distinguish between them in the future, and this is why I'm doing this research, is those brain-based biomarkers that we can see through MRI or other neuroimaging techniques. I just wanted to mention that.
That's a great point. And also there's a lot of different reasons why somebody might be expecting a subjective cognitive decline. So sometimes this can happen because of low mood, for example. So if people are feeling depressed, sometimes that can lead to changes in thinking abilities and then worries about those changes. But treating the depression might actually resolve that subjective cognitive decline. And so there are some modifiable risk factors that kind of interact with it. And not everybody who has subjective cognitive decline goes on to develop Alzheimer's disease. Some people get better from that. And so it is worth having that conversation also so that you can have a more positive trajectory, I think.
So many great questions here, and I feel that we're not going to be able to get to them all, unfortunately. So please note that I have put Jodie's email in the chat box. I'll put that one more time again here. I've also put our research email, research@alzheimerbc.org. You can also email us with your questions, and we can also help look into them for you. So let's see, there's an important question here that I want to make sure gets covered. How can we overcome stigma or resistance to seeking psychological help?
This is a great question. There is nothing to be ashamed of or worried about in seeking psychological help. It's exactly the same as seeking help for any kind of physical concern that you might have. It's so important to take care of your brain, and I think the care providers that would be waiting to see you are really welcoming and open to hearing your concerns. And so really encourage you to reach out if there's anything at all that you'd like to talk about, mood symptoms, changes in your thinking skills, all of these things we could help with. So definitely reach out to your care provider about any concerns that you have.
Thank you so much, you three. Can we go on to that last slide? Wonderful. So we've come to the end of today's presentation, and I wish we had more time. We had so many amazing questions. Really great to see everyone so engaged. My colleague Sarah has put a survey in the chat box, and that really helps us know how you felt about today's presentation, what sort of webinars you want to see in the future. It really helps inform the offerings that we provide. And it'll take less than 3 minutes, so we really appreciate you looking into that survey. And we know that living with dementia is hard, and we invite you to stay connected to us and others who share many of your feelings and experiences. And we have a lot of programs here at the Society to support you. We're happy to set up regular phone support where we can give you a call every few months to check in. We have telephone and video support groups. And we have Minds in Motion Online, which is a weekly fitness and social program for people who are in the early stages of dementia to attend with a care partner, family member, or friend. So to find out more about our other supports and programs, please call our First Link Dementia Helpline. We're offering webinars like this every week. So next week, we'll be talking about traveling with a person living with dementia on Wednesday, July 28th at 2 p.m. And if you want to watch this webinar again or share it with a friend, a link to a recording of this webinar will be on our webinars page within a week so that you can watch it again. So thank you so much to our wonderful presenters today, Ashleigh, Lisa, and Jodie. We learned so much. It was incredibly engaging and informative, and we're so appreciative to everyone as well who tuned in. So thank you so much. We hope you enjoy the rest of your day. We'll hang around here for a few minutes if there's any last burning questions, but take care, everyone, and we really appreciate you tuning in. Thank you.
Thank you so much for having us, and thanks for coming today, everybody.